And really the changing world that we've lived in really has lent itself to, I think, sometimes the medicalisation of sadness. Okay, and there's a great book written by a guy called Horowitz who actually has written about that have we medicalised sadness? So your question's around how do we differentiate possibly sadness to what's this beast called clinical depression?
Hi guys. This podcast explores the importance of our connection, well-being, and mental health. To reason with someone is to motivate them to do or accept topics, ideas, and issues through discussion and having conversations. This podcast is for those that want to raise their awareness, change their perspective, or just have a good time. My vision is to help people find reason to live, to grow, and to understand. I do that through this podcast, as well as counselling individuals that want to help themselves.
No, he needs to know.
I just think he's gonna talk and it's gonna make a lot of sense.
Hold up. Wait a minute. Something ain't right.
One man, one podcast. 3, 2, 1.
Reason With Me podcast, episode 16.
Welcome back, guys. We got the first psychiatrist on the podcast today, Dr. Mark Rowe. He's a consultant psychiatrist who has a special interest in managing mood disorders and adult ADHD. He's been a visiting medical officer to the Northside Clinic in Greenwich, which he worked in the specialist mood disorders unit. His interest in mood disorders involves subtyping depressive disorders and diagnosing accurately persistent mood disorders, which may have failed to respond to previous treatments. Mark utilizes the MAP, or Mood Assessment Program, which was developed by the Black Dog Institute. This helps assist the assessment of both unipolar and bipolar conditions. Dr. Rowe has a familiarity with a variety of pharmacological treatments used in the management of mood disorders. He has been on the advisory board for different pharmaceutical companies. Dr. Rowe sees patients with a provisional diagnosis of primary mood disorder or of attention deficit disorders. He sees patients with mood disorders from age 15 and onwards and ADHD from 16 and onwards. Mark is an awesome psychiatrist. He has a world of knowledge and I can't wait to start picking his brain about all things depression, and I hope you enjoyed today's podcast. All right, Mark, thanks so much for being on the podcast.
My pleasure, Jackson. Thanks for inviting me. It's a great to be on.
Awesome. So we'll jump straight in, Mark. Why don't you tell us who the hell are you and what do you do?
Okay. Well, my name's Mark Rowe. I'm a psychiatrist. So that's a medical practitioner who's subspecialised in the discipline of psychiatry. So a lot of people get us confused with psychologists. And so essentially the major difference there is that psychiatrists are doctors who have, as I said, subspecialised. So like an orthopaedic surgeon, he's a doctor who's subspecialised in orthopaedics. A vascular surgeon is a doctor who's subspecialised in vascular surgery. So I've subspecialised in mental health disorders. Whereas psychologists have gone to university and studied psychology and then normally done a master's or a clinical application of their theory of psychology. So essentially a lot of people talk about the difference as being, oh, you're the guys that can prescribe pills then. All right. And so it's a lot more than that, unfortunately. I think a lot of people feel that, I go along to the psychiatrist to get my pills and I go along to the psychologist to have a nice chat with them. But obviously a psychiatrist should be able to incorporate both of those aspects of management. And I work full-time in a private practice facility, Jackson. So essentially seeing patients that primarily have a referral around mood disorders. So that would include depression, bipolar disorder, and mixed with some anxiety, and also patients with ADHD is the other area that I've got an area of significant interest in.
All right. So that's really insightful. And I think, a lot of people do sort of put you into this box that is, the pill pusher,
Yes.
Which, I guess it is so much more, especially when you're studying and expertising in such significant areas that need support in. I think you guys and your voice is so important. So you said your main area is depression and bipolar. What made you sort of go down that path, Mark?
Yeah, look, it's interesting because a lot of the training of psychiatrists is public hospital training. That's exclusively where you train. And a lot of the presentations to public hospital psychiatry are often psychosis, depression also, but perhaps to a lesser extent. So private practice psychiatry can be very different. I think I've always lent towards the idea of trying to help people. You know, that's how I emerged into medicine in the first place. And I see depression as an area which I guess all of us can identify with to a degree, because we've all had, we'll talk about this perhaps a little bit more, we've all had depressed days. And so when you see someone who's had that pervasively and you know, living with it on and off for a long period of time, I think you can over empathize or empathize in a sense. And as opposed to illnesses like schizophrenia, which are, you know, very different type of illnesses where psychosis is something that very few of us may have experienced, certainly to that extent. So I think I identified with people, not technically ever had clinical depression myself, but identified with what that's like. And of course, there's a large number of people, you know, it's one of the commonest presentations to psychiatry. I've talked a lot about schizophrenia in public hospitals, yet there's only 1% of the population that have that disorder, yet depression is much more prevalent than that. So that's how I sort of developed an interest. I think it also lends itself well to both biological and non-biological types of management, whereas some of the other areas of psychiatry perhaps less so relatively. And then I emerged into the development of bipolar disorder because I thought it was very interesting when you see that if people are wrongly diagnosed with having what's called unipolar depression or one-directional depression, that it can make a huge difference in their delay in accessing appropriate treatment. So, yeah, I guess I just did my rotations in psychiatry, and I gravitated towards that area.
Yeah, I think that's, I mean, it's so true. It's so prevalent. I think it's 1 in 5 now at the moment. People can have experienced depression in their lifetime, which is pretty drastic. And yeah, like you're saying, a lot more significant than the 1% of Australia who have schizophrenia. So I think that makes sense. So obviously and what we'll talk about, yeah, definitely a little bit later, more on this depression and the scale of it all, and maybe like the different types. But you must be seeing a lot of people with all different types, and then there's a bipolar, and then there's all the potential trauma that's coming with all of that as well. So, you know, obviously you studied a long time, and you know, doctor on top of that is one thing, but then seeing these clients day in, day out, where do you pull your strength in order to do the work that you do?
Yeah, look, I think you either innately have that desire and ability. Someone asked me this the other day, and I said, look, I'm one of 3 boys. I'm the middle. I've got an older brother 6 years older and a younger brother 3 years younger. And I found myself, if my older brother had a fight with his girlfriend, I found myself sort of consoling her as a teenager. So innately, I do like to please people and ensure that people are feeling okay. So seeing people in distress, I feel uncomfortable with that. So I think I naturally had that desire, and I enjoy day in, day out. I don't think you can fake it in this game of communicating with people. There are aspects I don't enjoy, like the paperwork, and I think I can join the queue with a lot of others around that, but the actual engagement with other human beings, which lends me to your question, I get my strength, I guess, from my family. I think the most important thing in life, I often ask patients, what is life about for them? And I think it's about the human beings that you travel with throughout your life, whether it's your family, your best friend, your work colleagues, etc. I mean, we're innately gregarious animals, and for the majority of us, there are a small percentage with certain personality subtypes that aren't, but we're mainly gregarious animals. And that's where, you know, it's like going on a holiday on your own. It's not that exciting, or, you know, having a triumph internally. You want to share that with the people that are closest to you. And, you know, so I get my strength really from having my family around me. And with COVID, currently I've got 2 adult daughters, and they're living with us, so it's really good. And of course my wife, even when going through training to become a psychiatrist, I always wondered about how the female registrars who were young mothers and were able to manage a household and then try and get study and put it all together, whereas my wife would kindly, park off my time and make sure that I was available to do the study. So I think it's like a lot of people say, you have a lot of people behind you to turn out there. So that's essentially where I get my strength, I think, Jackson. Yeah.
Yeah, and that's a lovely answer, and I think that is so important. And you're right, we're innately drawn towards others and finding that connection. And I think we always strive for that in whatever way it looks, whether it's friends, whether it's family. So you're right. I think it's very hard to do the work, this type of work, or just holding space for people when you don't have a good support system or a good stable base for yourself.
Yeah.
Absolutely. Yeah.
Plus, I've also got 2 dogs wandering around here, and whatever day you've had and I open the remote control garage door, they're wagging their tails, looking forward to seeing you, whether you've had a fantastic day or a not so fantastic day. They're very consistent in their in the way of engagement.
That's so true. They don't care what you've done. They don't care whether it was a good day or a bad day. They're just here and they're stoked, and that's just the purest unconditional love there is.
Yes.
So true. Yeah. Oh, that's good. We've had a couple of dogs zoom past on the podcast before.
I'm sure you would have. You might hear mine if a dog runs outside. You might hear mine start to.
That's okay. Any input's good input for these chats. So I'm sure they're trying to deliver some sort of communication that's important for us to hear.
Yeah.
So just going down the line of depression and in a little bit more detail, I guess, there's plenty of things I could have picked your brain about today, Mark. And I think that depression is probably the topic that I wanted to go towards. So I guess reason with me and others, and tell me like the importance of understanding depression and maybe some of the different types. Like you said, everyone experiences depressed days, and when do we need to start being aware of that and checking in?
Look, I think it's really difficult, Jackson. It's not clear cut. People think, there's a medical illness like streptococcus pneumonia, where you can go into the doctor, you can say, look, doc, I'm coughing up, I don't feel well. He says, we'll get an x-ray done, cough up a bit of gunk, we'll put it on an agar plate where we grow the bacteria, and we can tell you what antibiotic works for that. And then every doctor can say, you've got streptococcus pneumoniae. The problem in psychiatry is that it's not as clear cut as that, okay? It's based on symptoms that are on signs, so what people experience themselves or what sometimes we can observe. We can observe depressive states in people. And really the changing world that we've lived in really has lent itself to, I think, sometimes the medicalisation of sadness, okay? And there's a great book written by a guy called Horowitz who actually has written about that have we medicalised sadness? So your question's around how do we differentiate possibly sadness to what's this beast called clinical depression? So sadness is a normal human response. I have patients that are going through grief. I have a lady at the moment whose husband died, and it's about 2 months down the track, and she says, I'm continuously crying. And I said, well, that's a normal human process to ensure that you remember that person that they were attached to you. So we can all have depressed days, and often I quote that, I'm a mad sportsman, and we may get into that later, or a sports fan. And I say to people, oh, my football team lost last night, I'm a bit depressed. Well, that's a normal human reaction, I guess, to disappointment, okay, or to an event that's happened in your life. And for that following day, you might say, I'm a bit down, or maybe 2 days if you're a really avid fan. But by next week, you're up and running and things have changed. Well, that's different with clinical depression. Clinical depression is essentially, one of the major factors is a time frame. So to be clinically depressed, or medically depressed, if you want to use that term, you have to have been down in the dumps for the majority of the days of the week for at least a 2-week time frame. Okay, and that's to try and eradicate sort of sadness that happens for people, or having a bit of a down day, as people quote. And that's one of the core parameters of the diagnosis of clinical depression, that time frame and having the majority of the days. The other thing that tends to happen in clinical depression as opposed to sadness is a big fancy word called anhedonia, which is the opposite to hedonism, and hedonism is to seek out pleasure. So it's the inability to derive enjoyment or pleasure from activities that you usually enjoy.
Yeah.
So if you have a sad day and you might go home and say, oh, well, I'm going to blast on that music, my favourite song, or I'm going to watch my favourite TV program, and you get a lift from it and it sort of alleviates your mood state, that doesn't happen in clinical depression. People struggle to find enjoyment and pleasure out of things that usually give them pleasure. And they're the two sort of cardinal sort of entry criteria, if you like, into the diagnosis. And then we have other symptoms that we look at. So other symptoms that can occur with people with pervasive mood depression is sleep disturbance, which either can be too little or too much, or waking up during the night. We can have changes in appetite, which can go both ways, changes in weight, energy levels, etc., etc. And they're the things that separate, I guess, clinical depression from sadness or grief or upset or frustration, etc. And I think, somewhat controversially, I'd say that maybe why we have gone a bit towards medicalising sadness is the nature of society has changed.
Yeah.
We're less community orientated in general. So I think we're less connected with our neighbours. So maybe when we were stressed 40 years ago, we'd yell over the fence to the neighbour and come and have a cup of coffee and whatnot. Now we're all relatively time poor. We're unable to do that. We may be internalising a lot of that stress, and it's coming out as well, I perhaps need to go to the doctor or the counsellor to talk about it. That's not, however, Jackson, to undermine, the seriousness of clinical depression. I think it's important that everyone has an appropriate screen, whether they are depressed or not. And so I'd say to everyone that's, listening out there, if you're feeling that way, definitely get an assessment, but not all assessments obviously will lead to clinical depression.
And I think that that's so important and so accurate. And we talk so often on the podcast like this is we're way more individualistic now, and we don't have that community base as we did. I'm sure there's plenty of communities that do try and flourish with that and try and bring that back into that tribe base. But
yes,
we are time poor. We are busier than ever, and we, especially in times of crisis like a pandemic coming out of nowhere, we don't have the same outlets. We then stop doing these things that we have access to that were at least trying to get us out of this thing. So would you say that you've seen an increase in clinical depression, or at least people coming in for assessment?
Yeah, certainly people coming in for assessment. I think there's a better community awareness and societal awareness, thanks to you doing things like this, and institutes like the Black Dog Institute and Beyond Blue, and celebrities or well-known people prepared to talk about having had their experiences with mental health disorders. I mean, it's not dissimilar. I heard many years ago, I think it may have been 5 or 10 years ago now, Kylie Minogue had some breast cancer scare. And I understand that the number of people that presented for mammograms, young women that presented for mammograms that year, was phenomenal because of hearing her story. And I think it's not dissimilar when people talk about depression. And there's a Premier of Western Australia, Jeff Gallup, some years ago, that gave a public speech about his depression. I think that helps others to think, because one of the biggest things that I've been fighting, I guess, or all of us have been fighting in the battle working in mental health, is stigma. And I'm sure you must have spoken about this previously, and it continues to be a huge issue. And to that extent, I say people are prepared to talk about depression, but no one's prepared to say, look, I have had a psychotic process or whatnot, because they're still deemed to be very stigmatizing. And if you have a look at psychiatric hospitalizations where people used to live, so-called chronic hospital institutions, most of them splattered across the country were actually river access. So we're going back to the bad old days where they wouldn't bring mentally ill people in through the normal part of the city.
Well, it was illegal, wasn't it? And the king wouldn't allow it or something, and they had to go underneath so that they weren't allowed on the king's streets or something like that.
Yeah, but I'm talking about even in Australia. So where I worked in Queensland, in Brisbane, prior to moving to Sydney, the jail is adjacent to the chronic hospital at Boston Park or Wago. So it's, you know, this is still the biggest issue. And a lot of people, getting back to the difference between psychologists and psychiatrists, is a lot of people feel it's heavily stigmatized to see a psychiatrist, whereas psychologists carry less stigma because, you know, you can so-called be a worried well, I guess, without having that stigma. So it's a huge issue that still emerges. And I have occasionally patients that say to me, "Oh, doctor, can you give me a certificate, but on the letterhead, not write that you're a psychiatrist?" Because they're ashamed, in inverted commas, to present that, or they're worried about how work colleagues are going to perceive it. So, and the only way we can beat stigma is through education and community involvement. In fact, I don't know whether you're aware of it, but there was a fantastic movement in Italy, in Trieste, in Italy, where the society got behind people that were locked up in chronic mental health institutions, and they actually made it sort of not compulsory to be in, you know, there's a law against compulsorily hospitalising people for long term, and they provided jobs for them in the community, and it was a sort of mini uprising, if you like, and like a lot of change, you know, needs to come from community. So, but I think you know, Black Dog Institute, a lot of advertisements now on TV. You would never have seen those advertisements years ago. If you're feeling anxious, what it is, etc., etc. So, so getting back to your question, yes, more people are presenting, but I think whether there's a real increase in the cases of depression, or whether we're seeing more because people are presenting more, I guess becomes the question.
Yeah, that's true.
And the changing nature of society, you know, as you said, our outlets are not as prevalent. And arguably that all comes from quality of life. Our actual quality of life, in my opinion, has dropped because for the average person to own a home compared to years ago, the hours that you need to work to do that, it means that our actual quality of life has dropped a little bit in that, if you equate it on those grounds.
And I think, you know, that busyness that then creates for people, definitely something that I'd like to hear your opinion on. But a lot of people are going quick fixes. Let's go to the GP and get diagnosed with, get prescribed with Lexapro, and then I'll do a round of whatever that lasts and just wait until I feel a bit better, with no actual commitment to anything besides the medication.
Oh, absolutely. There's a huge subset of that out there, Jackson, and that's multifactors contributing to that. I think one factor that you may or may not be aware of is the nature of the antidepressant has changed. So the tricyclic antidepressants that were used prior to the development of Prozac, which is the so-called new generation antidepressants, they have issues around side effects, particularly in overdose and lethality around cardiac concerns. So GPs wouldn't be as ready in that era to be prescribing those medications without perhaps a psychiatric assessment. The advent of the safer and arguably more tolerated, even from a normal side effect profile, SSRI medication that we tend to use these days, it's easy to prescribe them, and therefore GPs are time poor as well. I mean, you can go into the financial aspects of, if you're a GP having to spend 45 minutes with a patient to take an adequate history, talk to them, etc. From an income perspective, relatively, you're being compromised as opposed to seeing 3 15-minute consultations. So that's one of the factors. The other factor is the patient demand. The patient goes in and said, "Look, I haven't got the time or money to be going and seeing a therapist, doc. Can you just give me something now?" So I think, that's another factor. Pharmaceutical companies, arguably, they tend to be pushing biological managements. I mean, a lot of the discussion now, certainly worldwide and within the College of Psychiatrists, is how much can pharmaceutical companies sponsor education of doctors in as far as conferences and information they're giving them, etc., etc. And one could say, well, it's necessary to have any education about a new drug, but my concern about that, or mild concern, is that maybe that's the only way you're being educated as to how to manage certain illnesses. You're not getting a global,
Yep.
you know, the drug companies are may not sponsoring a cognitive behavior therapist to come and talk at the conference and deliver that, or a mindfulness-based therapist coming to talk about that delivery. So there are some concerns that either innately or subliminally you may be thinking, first thing, let's go to a medication. And certainly GPs are getting a lot of their knowledge around medication via that avenue, because they can't be across everything in the same depth as what specialists can be. So look, it's multifactorial, the answer to that question, I think.
Yeah.
Jason,
Yeah, and definitely a Pandora's box sort of question.
Yes.
Sometimes they are like that, though, and I think the response you gave is exactly right. There's so many things that make up this. I guess the one thing that I'm interested in with that is the people that are going and seeking, the GP support and wanting to do that quick fix, and the supply and demand of I guess, we want it now. I think you mentioned now. These medications, are they okay to be doing them by themselves, or are we going to see change for people's moods and people's depression, or do we need to couple that with other things?
Yeah, look, it's once again, that's a Pandora's box question. I mean, there's no doubt that the management of any mental health disorder, what innately we're trained to think is biopsychosocial. So there are biological factors that you may need to manage. There are psychological factors that you may need to manage, and there are social factors that you may need to manage. In fact, in psychiatry, when we're trained on something called a multi-axial system, which is 5 axes of viewing a particular person when they present. And axis 1 is a major mental health disorder. So it might be they're diagnosed with depression or substance abuse. And that's obviously your axis 1, your primary focus. But axis 2 might be their personality style or personality disorder that may be driving an interplay as to how they're presenting or how they're experiencing the depression. Axis 3 is physical illness. So if I've got asthma and I get short of breath, and I've got anxiety, I might get terribly anxious about my shortness of breath, okay? Or if I've got thyroid dysfunction, which can be a cause of depression, that may be driving my axis 1 diagnosis. Axis 4 is psychosocial stresses. So why might I be depressed if I can't pay my bills next month, or I'm living in an abusive relationship, or et cetera, et cetera. So axis 4 may be driving axis 1. And axis 5 is something called the global assessment of functioning, which is out of 100, how functional has that person been in the last either 3 or 12 months, depending on how you look at it. So I think when someone presents, it's not as simple as, okay, this is depression, I'll give them an SSRI, okay, or a Lexapro. It's about, why is this person presenting? I say to myself, why is this person presenting to my rooms at this point of time now, okay? And then you've got to look at what those are. And to that extent, I might give a bit of a plug for this, so to speak, but there is a tool that I tend to use developed by the Black Dog Institute called the MAP, M-A-P. It's an acronym for Mood Assessment Program. And what that is it's an extended questionnaire type of approach, which looks at multiple factors. You know, what are the stresses in that person's life in the last 3 months, 12 months? What are their personality traits? Is this likely to be part of a bipolar disorder, etc.? And it's a tool that the clinicians that use it can find very helpful to make sure you're not missing some of those biopsychosocial factors that are contributing. Around whether I think you're sort of half asking, are they dangerous? Is it dangerous, or what could be an outcome of doing that? I guess the biggest danger is neglecting the other causes. Yeah. To me, you know, I've seen many people get treatments for a biological disorder when really it's around their attachment to their parents, or abuse history, or you know, bullying in the work environment that they're experiencing, and they've presented with, I'm not sleeping well, I'm not those necessarily core symptoms that I said of depression, that pervasive mood disturbance and anhedonia, but they're presenting with those other symptoms, and the doctor's GP perhaps or otherwise has spent 5 or 10 minutes with them and said, look, I'll give you Lexapro. So what happens is then you start off this or it's not working, and you can then go down the next path, or we'll try a different antidepressant, we'll try a different one, etc. You've got to go back. And that's why when patients are referred to me and they say, look, I've seen such and such diagnosed with depression, I sort of have a saying, love many, trust few, and always paddle your own canoe. So I want to take a new history, okay, and make sure for myself that it's incorporating what I think might be contributing to that. And you may not even get that information on the first instance that you see someone. Like, I saw a lady who always had a husband accompanying her to the appointment, okay? And it came out after about 10 or so sessions that there'd been some childhood abuse perpetrated by her brother, but she was too ashamed to sort of acknowledge that in front of her husband. So there are lots of different scenarios where it can complicate whether antidepressants. There's also Professor Parker, who is a psychiatrist that's well renowned here in Sydney and was the head of the Black Dog Institute for many years, who I had worked with when I first came to Sydney. He's often asked the question, why do you think there's been an upsurge in bipolar 2 disorder, which is something we may or may not get a chance to talk about. And one of his thoughts is that maybe there's an overuse of stimulant medication for ADHD in younger people now, and that may be triggering a sort of, the mood regulator, if you like. It's just a theory. There's no firm evidence to support that. But, could SSRIs, one thing that we do know about SSRIs, that it can emotionally flatten people.
Yeah.
So people will often talk about just not feeling as a result of taking their medication.
Plateau.
So sometimes, plateauing. Emotional numbness is probably another term that's used for it. So they're not depressed because they're not as crying or tearful, but they're not actually joyful either. They're just sort of flattened. So, I think the major concern about prescribing antidepressants is if you're missing what the other causes or other contributing factors may be to that presentation. Yeah, essentially.
I think you put that so well. I mean, you did a great job in keeping it, not up here with all the psychiatry side of things. I think I understand it so well, and I'm so glad that those tiers or whatever you call them,
axes,
are happening. And I think if we start to think about that as a community, then we're going to do better. A GP doesn't have time to do those.
No.
So a GP is going to say, boom, here you go. Or the patient's going to say, this is what I want, blah, 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 had it. This is how it's going to work for me. It's like the map from the Black Dog, and I'll put that on my website. But that, and then having this theory of all the other factors, biopsychosocial, but all these other things and underlying causes, like that's what we need to be looking at. If I take Panadol and I keep bashing my head against the door, I'm going to still have a headache,
Correct.
So I've got to look at the other factors, like, okay, that's probably causing the headache, I got to adjust that. And I think it's exactly the same with our mental health, and we can't take those things for granted.
Absolutely.
Yeah. Well, I'm sort of taken aback by your response, because I think it's so well put. With especially how we see depression, and there's so many other things that are at play, and that one thing that leads to the other thing that leads to the other thing it's true.
And that's the trick, I guess, in being a holistic practitioner, if you like, Jackson. I mean, some people will just do psychotherapy only, perhaps, and miss the biological. Some will just do biological only and miss the psychological. Some won't look at the environment that the person's in, that they're unemployed, that they've got no validity in life because of that. And that's the tricky part, negotiating all of those domains, I guess. And so that's why I like to work perhaps closely with psychologists as well, but quality psychologists that I can entrust to ensure that. And a lot of people like to delineate between those two areas, so that there are some psychiatrists that are purely talking therapy only, and they'll say, can you do the medication? Because the patient will want to come back to the medication as an explanatory. Well, doctor, why aren't I better? I'm taking it. Whereas someone can park that and say, no, talk to Dr Rowe about that. I'm going to focus on these difficulties that you're having in life. So, and of course, all of this is, as we've alluded to, how the expense and the cost of this in society. So one of the systems that's wrought is the public mental health system, where you have to be terribly unwell to be able to access it because they've got limited resources. And then there's the private system, which can be arguably relatively costly for the average Australian. So there's that big gap in the middle. And, with the advent of Medicare funding psychological sessions for 10, I think up to 14 in rare circumstances in a calendar year, it can help, but it's, some people need a lot more frequent assistance than that. So I'm aware of that. I'm aware of that major gap in the system. And also the public system is more of a crisis type system rather than a enduring health maintenance type of approach due to resources. Really, I don't think people working in there are going, oh well, I only want to patch up. They want to do that holistic care, but the resources in the system and the cost, which is a big issue.
Yeah, I think that there's so many different ways we could go in and talking about all of those. I think that there's just a lot of different spot fires that the government or our society try to put out at one at a time. But it comes back to this thing, like we're complex. We're so complex. Humans are we still don't understand what we need to be understanding about the brain.
Yes, that's right.
We got to treat people as a whole and as well as ourselves. And I think that's where we need to start, not this backwards think of prevention and intervention. It's like we need to just be more aware of what's happening with us and others.
And you've alluded to one of the other, one of the questions is, what gives you strength or what keeps you going. I love this specialty of medicine because every single person that walks through the door is a different individual. And I often say this to patients, that if I'm a surgeon and I'm my 6th gallbladder for the day and it all looks the same and I poke through the chest and my laparoscopic thing, for me that would be relatively boring. Okay, even though people say to me, how can you see people with depression all the time? Well, I get to see different personality styles, different age groups, different genders, and everyone brings their individual flavour to how they experience it. So I'm known by my patients of taking this sort of intrusive history. I even ask about pets, which is something that I've sort of added in recent years as to whether people have pets, and I sometimes get a quizzical look. But I've come to find that some people who have had trauma, particularly being misused by other human beings, will have a over attachment sometimes, if there can be such a thing, to animals, and it can be a lead into that often people talk about loving animals more than people in their lives. But
so important. I think that's not intrusive at all. I think it's so great. I think it's so necessary because we've got to find out what works for people and what helps them.
It's part of people's family, isn't it? Really.
So I guess that keeping that train of thought, Mark, what works for you? What, in terms of filling your cup back up, what's non-negotiable for you? You mentioned you're a big sportsman, but what do you do for self-care that's non-negotiable?
Well, look, as I mentioned, I love communicating with family and friends. As I mentioned, I'm one of 3 boys. I was just been on the phone to my brother. Yeah, so with my brother, I talk with him frequently. Obviously, with my wife and children, to share their days and normalise you and equalise you, takes you out of a field. Actually, one of my daughters is a nurse, so. Not in mental health. She works in the spinal injuries area, but often she'll talk about some aspects of her day. So I think that's showing. What they do know is non-negotiable is Dad on a Saturday and watching sport. I'm a mad rugby league fan, and that once again emanates from childhood. A lot of things are rooted in your childhood modelling and whatnot. And when I lived in Brisbane, my father was keen on horse racing. I was keen on rugby league. He would drop me off at the Suncorp Stadium, then Lang Park, and on his way to the race pick me up, and I'd watch three grades of rugby league football, even as a 10-year-old. So it's been in my blood, and played it, and all 3 of us had played it. So that's where that interest lies. And I'm inherently competitive too. My kids will tell you if they beat me at a game, they've beaten me. I haven't been gentle of, and said, well, look, I'll let you win. So, but I guess the answer to your question is you get your strength from your patients. And, I think to see people improve and, their lives change, there's no greater gift. There's, a lot of young people are gravitating towards wanting to do psychology. I think the attraction of helping other human beings is a privilege, and every day when I go to work, I realise what a privileged job I have. Particularly when there are other jobs out there that aren't as rewarding. Obviously, people say to me, "Oh, geez, there must be terrible days." And yes, I've had patients, take their own lives, and those things can affect you significantly. But the vast majority of my work, I enjoy that interaction with people. So that is a large chunk of my life. So, I forget whether it's Freud or Jung who coined the term work, love, and play. You need an equal sort of pie graph of those three things in your life, and I think that's what I sort of just described without formally looking at it in that avenue. So work's a big chunk of joy, love with family and friends, and I'm about to go out to lunch with 3 other male friends of mine shortly, and the play is that recreation with football and whatnot, which or any sport. I often say to people, if Chinese marbles was live broadcast at World Championships or something, I'd be watching it. So that's the sort of attitude I have towards sport. Yeah.
I love that. I think there actually was marble racing was one of the only things when all sports stopped with COVID.
Okay.
I literally was watching marbles run down.
Oh, right.
It was very funny. I was like, when the AFL and the rugby league and the rugby union slowly came back, I was like, okay, I think I could do better than marble racing now.
Yeah, but you'll take what you can get. Yeah, that's right.
That's right. We do what we can. But yeah, I think, those are really nice answers. And I think, you do cover all those things, and it's interesting because it can't just be one thing for self-care. It has to be multiple, and it has to be an inventory of things, because, if walking's your thing and it's raining, you can't decide I'm not going to do anything then. You've got to think of something else that's going to fill that cup back up. So all those responses are good. So Mark, last question for you is, what would a go-to book for you be? What's something that's been a big inspiration for you, and what would you I guess what stuck with you and been a big...
You don't necessarily mean clinically, do you? You don't
mean there are a lot of clinical books being dropped, but whatever.
Okay, well, I've got a perfect answer for that question, Jackson. This book I was first introduced to by a psychiatrist colleague of mine after my mother passed away. So my mother passed away from breast cancer at age 60. That's many years ago now. She would have been 78 this year, so 18 years ago. And, going through my own grief reactions, et cetera, a psychiatrist colleague said to me, why don't you get a hold of this book called Tuesdays with Maury? Okay. And I said, oh, well, why? What's it about? And she told me a little bit about it, but obviously left the rest of it up to me. And it's written by a fellow called Mitch Albom, Albom. And it's a true story of a sports journalist in the United States called Mitch Albom, who was commenting on a basketball game or something. And at the end of it, he saw a CNN alert. And it said, tonight we're talking with Maury Schwartz, who's diagnosed with Lou Gehrig's disease. Now, Lou Gehrig is also another famous name in the sporting world. He was a famous baseball player for the New York Yankees years ago. And he developed this progressive neuromuscular palsy, okay? It's neuromuscular degeneration disorder, which kills you. And Lou Gehrig, it was named after him. And Maury Schwartz had developed this illness. And Mitch Albom's connection with him was he was his sociology professor at university. And he was a very enigmatic, charismatic type of teacher that Mitch obviously had a lot of time for. And Mitch decided on that day that he was going to try and get hold of him. And he actually made a phone call and said, Professor Schwartz, this is Mitch Albom. I heard da-da-da-da. He said, you remember me? And of course, Professor Schwartz has had many students through. I don't think he actually remembered him, but he said, look, I'd like to catch up with you. And so what happened was Maurice Schwartz, it's sort of argued that his last lesson in life was educating his young journalist student on what life's about. Okay. And as he was dying from this disease, he was able to give to Murray, and it's called Tuesdays with Murray because every Tuesday, Mitch Albom would go over and meet with him, and he recorded a lot of what the interactions were. And it's a book that my wife says to me now that, every 6 months you should read if you're, thinking about, where life's at. So the problem with it, of course, is, unfortunately I have to say this, when I have a copy in the rooms and I lend it to someone, I never get it back. So it's the old adage, don't lend your books out. But I think most people will find that an interesting book. It is, but it's got the worldwide, phenomenal sales about it, because I think Oprah Winfrey advertised it on her show many years ago. So,
Okay.
It has that. But that's a book that I think is very inspirational.
Tuesdays with Murray. All right. We'll put that up on the website as well. Along with, where can people find you, Mark? And I don't know, what do you have available, and maybe, and even if there's some writings that you have.
Yeah, well, look, I've done a little bit of, there's still a little thing I think on YouTube that I did where I worked at a former place at Lawson Clinic, a little bit about what is depression. We haven't got into the subtyping yet, so people can go on there and have a look at that. Where I work, we're developing our website, we're updating our website. It's not a very thorough one at the moment, but I work at the Greenwich Specialist Consulting Rooms. And there we're going to attach a few things. But if people are looking at information, not necessarily about me, the Black Dog Institute, I think, has got a myriad of information, and I recommend that to most of my patients. I did do a webinar on bipolar 2 disorder with another professor, more geared towards psychiatrists, so more at that level a few years ago, called Black and Blue Bipolar 2. I'm not sure still whether that's publicly accessible. It was for a long while. I'm just not sure whether it still is now, Jackson. But but obviously, my main, I'm not technically an academic, so my main thrust of work is seeing patients. And I work 4 days a week at the moment, starting at 7:30 and finishing normally about 6:30, so full on, and having the 1 day a week, one work Wednesdays where I'm not working at the moment. So if people need to see me or need to see one of my colleagues, etc., the Greenwich Specialist Consulting Rooms is where I'm working out of at Greenwich.
Well, I will do some digging, and I'll see if those things are available, and I'll put them on my website, Mark. The couple of webinars that you've done, and then the Black Dog, I'll put that up there as well. So I guess, Mark, it's an honor to have you in the field. I think this has been so important, and I think the work that you're doing and just the knowledge that you have it's so pivotal in people's understanding and just I guess the passion of the work that you do, and that sort of comes straight through. And it's an honor to have you on the podcast as well. So thank you very much for coming.
Been a pleasure. Thanks for strongly encouraging me and inviting me. It's lovely, and who knows, we may need to do it again soon.
Yeah, absolutely. All right. Thanks so much, Mark.
Thanks, Jackson. Cheers, mate.
Do you want to find out more about how therapy can help you kick some goals? Go check out findreasontherapy.com.au or the Find Reason Therapy Instagram page.